We're going to talk about bladder cancer. We have Vic Malhotra from the Florida Cancer Specialists joining us, as well as Drs. Galsky and Rosenberg. And so we're going to start out in a minute talking about non-metastatic urothelial bladder cancer. But you know what I'm going to start out talking about here, which is EV Pembro, because what a story, what an incredible story. One of the most interesting stories, I think, in all of oncology. You know, you all were really leading the ADC revolution. You had 2 approved ADCs in metastatic disease, where most of these other diseases didn't have anything. And now, in one swell swoop, you came in there with an ADC, so enfortumab and Pembro, a randomized trial against platinum-based combination, Jonathan, that beat the hell out of platinum, and that's first-line therapy. Any thoughts about how this evolved? Is really an amazing story, and also why it's so effective. Is it in the IO ADC? Is there something different than IO chemo, for example?
I think there's a couple of components. One is the contribution of the antibody in terms of not necessarily just the binding and delivering chemotherapy, but in fact, it's the bringing immune cells to the tumor. And then when you bring the immune cells to the tumor and then activate them with the checkpoint, you really have pretty dramatic responses. And I also think the payload itself probably is playing a role in terms of immunogenic cell death, providing the substrate for the immune system to work on. And so it really was fortuitous in many ways, but once the activity of the ADC looked so promising, it made a lot of sense to combine it with a checkpoint inhibitor.
You know, it's interesting, Matt. I think there was a period of time when it was only approved in older patients who are not cisplatin eligible. And I remember looking at the data going, I think that's what I'd want to get, whether I was platinum eligible or not. Right. And again, any thoughts about how this sort of exploded onto the scene and just totally changed everything?
Yeah, I think it's a really interesting story, particularly in bladder cancer, because what was working in every other solid tumor, combining traditional chemotherapy with immune checkpoint blockade, just hasn't worked out as well as we thought it was going to. Jonathan's going to talk about that a little bit more. And I think there are nuances to that story. But while that was getting sorted out, we had new drugs being developed in urothelial cancer and combined them together, and it was a home run.
So I'm curious, Vic, what questions you have about it. I don't know that this is necessarily a walk in the park toxicity-wise. You would think, okay, now we don't have to use cisplatin. But, here are some challenges there. Vic, anything in particular you'd want to ask them about?
Yeah, I think the big question is obviously responses are great, but skin toxicity, how do you handle it? That's been a common problem in my practice.
I mean, I tend to see the patients frequently, which is at least early in the treatment, and identify toxicity early and intervene quickly. The rashes that are the dangerous rashes are the blistering rashes, the ones that give bad mucositis. You have to be comfortable not dosing and skipping doses, and I don't think that really is to the patient's decrement. And so it's manageable, but it's a very substantial percentage of patients and requires intervention. Become good friends with a dermatologist. Right. I think we're going to see some interesting work with novel cytokines or cytokine inhibitors to reduce some of the rashes in subsets of patients. And so there's probably some interesting biology underneath it too.
Have you seen benefit to changing the schedule or dosing with EV?
I think dose reduction helps.
What doses would you reduce by?
Yeah, so I usually just go down stepwise and see how it goes. Although if it's a really bad rash and I want to continue using the drug, I might go down from 1.25 down to 0.75 and skip the 1 mg per kg and maybe re-escalate later.
And no concerns about using steroids, either oral or topical?
Certainly, I use a lot of topicals, and for some patients, they may need a short course of oral steroids. There is the risk of hyperglycemia with enfortumab, and so you do have to be a little careful of that. So if you're seeing the sugar creep up, maybe try topicals. I'm not sure that orals work a lot better, but sometimes they work a lot faster.
Have you actually used EV Pembro at this point, Vic, or just EV alone?
EV Pembro.
And how did it go?
Excellent. Responses are great, and toxicity was just mainly the skin stuff is what I've seen, and some hyperglycemia, manageable though.
Any other toxicity issues, Matt, that come up with this combination?
I mean, hyperglycemia, like mentioned, not so common, but you have to look out for it in the neuropathy, and neuropathy is more of a cumulative side effect and can be dose limiting or treatment limiting, but that tends to creep up later. But I would say for the skin toxicity, like Jonathan mentioned, seeing patients during that first cycle is key. Sometimes you start a patient on treatment and, it's a 3-week on, 1-week off cycle, so you don't see them again for a month. But if they come to your infusion unit and mention a rash on week 3, then that rash needs to be evaluated.
You were bringing up to me also, Vic, the issue of neoadjuvant EV Pembro. Jonathan, do you see that? Obviously, neoadjuvant is a very important part of bladder cancer. Do you see this regimen coming in?
I think it's pretty likely. There's the benefit compared to chemotherapy is so substantial in the metastatic setting. You'd have to posit that it wouldn't be able to eliminate the sort of micrometastatic cells, and I just don't see that that's the case.
All right, well, now I can take a breath, because you have to talk about that. And now we can sort of get back to the regular, what we were going to talk about, beginning with non-metastatic urothelial bladder cancer. And we'll particularly want to hear about the adjuvant situation, but also the non-muscle invasive, Matt. And before you get started, I'm just kind of curious again, Vic, do you ever see patients get referred with non-muscle invasive? Have you used Pembro, for example?
I have, and actually we're getting a lot more referrals. My local urology group of very smart, well-trained people, stay up on data, so seeing a lot. So the challenge that I want to ask the faculty is, some elderly patients don't want to have cystoscopy so often. They go with BCG treatments, and we have some really high-grade non-muscle invasive bladder cancer. Have you used Pembro in that situation, and what is your take on it?
Jonathan?
At MSK, we're not huge fans of Pembro for non-muscle invasive disease. The long-term outcomes don't look any better than giving almost anything else, and the risk of systemic toxicities is substantial. So I think, yes, it's an option for patients. We do use it, but it's not something we use commonly.
So, Matt, agree, disagree, or in between? He seems kind of down on it.
Yeah, I'm in between. I think there are some patients for whom it represents quite a reasonable choice, but there's an explosion of new treatments for non-muscle invasive disease, and so systemic therapy is a little bit hard to compete with in intravesical therapy.
And speaking of that, the TAR-200 device, have you had any of your patients get that, Vic?
No, not yet. I've just actually heard it on your program. I've not had it.
I've been hearing about this the last year, so I know you're going to talk about it. But before you kind of show slides and all, can you just explain what it is? It's so interesting and different.
So TAR-200 is a silicon tube that's semi-permeable that can be loaded with drug. In this case, TAR-200 is loaded with gemcitabine. Gemcitabine is then released through an osmotic. So the device is inserted into the bladder using a cystoscope. It's a straight tube, but it assumes a pretzel shape once it's in the bladder so that it doesn't come out. And it slowly releases drug into the bladder over a sustained period of time through an osmotic gradient. And so in this case, it's gemcitabine, and really based on the premise that just changing the pharmacokinetics of drugs that we've used before can make a major difference. And I'll show you some data suggesting that that's probably the case.
And it really surprised me, John, to hear that erdafitinib was also being used with this device. I guess it's even more common to see FGFR in non-muscle invasive.
Right. For low-grade non-muscle invasive bladder cancers, which aren't necessarily life-threatening or dangerous, but come back a lot and need cystoscopies all the time, as was pointed out, those patients might be great candidates for a device like this. It's a slightly different device, but the same principle, in that it's slow release from the device in the bladder. You don't get the same systemic toxicities as you might with erdafitinib.
I know it's kind of a basic question, but any response about the patients who don't want to have frequent cystoscopies? I'm sure nobody wants to have it, but there are probably people who refuse it. What do you say?
So I would say what's on the table, what's on the horizon, maybe is a better term, to try and replace cystoscopy is urine tumor DNA. And there are preliminary studies suggesting it's looking promising. There are some challenges because there are some mutations that can occur in normal adjacent urothelium because of the field cancerization effect that happens in the bladder, which might make urine a little bit less clear-cut than plasma ctDNA. But I think it's coming. I think it's coming in the future.
Urine, that's interesting. What about for diagnosis?
For diagnosis as well.
Fascinating. All right, let's talk about non-metastatic disease and what we've learned in the last couple of years.
Here are my disclosures, and I'll start with a case. So this is a 78-year-old man who presents with hematuria. He has a CAT scan. It shows a bladder mass and then undergoes a transurethral resection of bladder tumor, which shows muscle-invasive urothelial cancer. He proceeds directly to radical cystectomy. Surgical pathology shows a pathological stage T3N0 tumor, and then he's referred to you for a medical oncology evaluation. He has a creatinine of 1.7. He has Signatera testing done, and it shows a detectable ctDNA at 1.1 mTMs per mil.
So, Jonathan, before you talk about how you think through the case, what about cystectomies in older people? At what age do your urologists stop doing them?
I mean, I'm very lucky to practice at a center with incredibly talented and specialized urologists who only see bladder cancer, at least some of them. And, you know, when you get into your high 80s, that's when cystectomy for them is a problem. I think as cystectomies get centralized into major tertiary care centers, I think, you know, it's a big hit to a patient, but many people can get through it with the right team.
So, Vic, I mean, this is considered one of the most morbid procedures in oncology. What do you find in terms of people responding to it? And are you seeing patients, you know, asking for bladder sparing strategies?
Absolutely. So again, my patients are elderly, and my local urologists, as good as they are, don't prefer to do a lot of radical cystectomies locally. So a lot of ours do get done at Moffitt for good reason, post-op care, all that stuff. So I think I would say probably more than half the patients, and age is not really cut off, but I would say older than 80, impossible. But even younger than that, patients will come in asking for chemoradiation. So we do a lot of that in our setting.
So, John, second opinion, this patient comes to you. Let's just say you don't have a Signatera. A, would you order it? And B, what would you do? What would you suggest to this patient?
I think the preponderance of the evidence is coming up that Signatera is a useful test in this scenario. And there's each month there's new data suggesting that it really risk stratifies patients post-surgery and maybe even pre-surgery in terms of their risk of relapse. And so this is a patient that's very likely destined to have his cancer relapse and have to consider additional therapy if they can tolerate it.
And what specifically might you be thinking about?
I think at this point, nivolumab based on the Checkmate 274 data, and then you could, even though it's not approved for that, pembrolizumab based on the Ambassador data.
And if the Signatera was negative?
I'd still consider it, but maybe less robustly. It's a more nuanced discussion at that point.
Matt, what's the follow-up here?
So this patient started adjuvant nivolumab.
How's he doing?
Doing well, about halfway through the year of treatment.
Nothing, zero tolerability issues?
No tolerability issues. Of course, there can be side effects related to immune checkpoint blockade in the adjuvant setting, just like the metastatic setting, but about 2/3 of patients get through treatment without much in the way of side effects.
How's he doing in terms of recovering from the surgery?
So had a pretty quick recovery time, and I think that really speaks to some of the points that were made before, which is one, proper patient selection. Two is high volume surgery. We know that surgeons who do this procedure a lot have better outcomes than surgeons who don't. And the center as well, it's just not about the surgeon. So that all that volume data takes into account the center. And there's been major advances in terms of perioperative care. So it's not just the minimally invasive surgery that's probably getting these patients out of the hospital faster, but this whole field of prehabilitation, right? How do you optimize someone for surgery before surgery, and then narcotics sparing, pain control after surgery, whole lots of advances that get patients out of the hospital within days.
You know, just listening to you, I wonder if, I mean, at least myself, I wonder if we've underestimated the importance of surgery and the right surgeon and the right hospital here. Vic, I mean, just listen to them, I'm thinking,
Yeah, I've had the experience initially, even the same thing locally when we have tried to do them. The outcomes just haven't been as good, and a lot of it is just post-op care and volume. If you have a nurse taking care of 10 of these a week versus 1 a month, there's a huge difference.
All right, let's talk about some of the data, Matt.
Okay, so I'm going to start, we'll talk about muscle-invasive disease. I'm going to start with non-muscle invasive disease. As medical oncologists, as we've discussed, you know, we don't see a ton of these patients, but it's important to know about these patients, particularly with a drug approved in this setting that's given systemically. So these are the AUA-SUO treatment guidelines for non-muscle invasive bladder cancer. And of course, non-muscle invasive disease comes in a couple flavors, right? There's TA tumors, papillary tumors, which are mostly low grade and sort of like polyps of the bladder. There's carcinoma in situ, which is high grade and sort of carpeting of the lining of the bladder. And then T1 disease tumors that invade into the lamina propria, but not yet into the muscle. So that the high grade tumors, carcinoma in situ and T1, those are high-risk tumors, and if you see the green part of the slide here, for high-risk tumors, standard treatment is BCG. BCG was introduced in the late 1970s, probably the single most immunotherapy that's been developed to treat cancer to date, and so remains the standard treatment since that time. Unfortunately, despite how well BCG can work, we know that patients develop recurrent disease despite BCG, at least a subset of patients do. And this was a drug development mess for years. And the reason it was a mess because it was really difficult historically to figure out who these patients were and to design proper trials with proper endpoints to demonstrate the benefits of drugs, because patients would come in with different recurrence patterns, different prior exposure to BCG, really lots of heterogeneity there. And so many investigators came together, really tried to solidify definitions of what it meant to receive adequate BCG previously, what the recurrence patterns were like, and how to place patients, so to speak, into clinical trial eligibility buckets that would inform drug development. And so that's really led to this definition in orange here that you see BCG unresponsive non-muscle invasive bladder cancer. And that's where the bulk of clinical trial drug development activity has occurred in the past several years. Some of these other buckets, there's now trials targeting those patients as well. Pembrolizumab, as mentioned, is approved in this setting, and you can think about non-muscle invasive disease drug development in this setting as really requiring two sets of trials or two cohorts within the same trial. And the reason that is because carcinoma in situ, as I mentioned, is sort of a carpeting of the bladder. That's not something that a urologist could easily completely resect. And so there's actually disease visible in the bladder after the diagnosis. So one could measure the response to a drug, like we measure in metastatic disease tumor shrinkage. You can measure response to a drug into the bladder before, where you have carcinoma in situ before, and then after drug to see if that carcinoma in situ clears. Papillary tumors, on the other hand, high-grade TA disease or T1 disease, that's more like adjuvant treatment. That tumor is resected. There's nothing that the urologist could see after that resection. And then you give a drug, and it's a time-to-event endpoint. And so very different development strategies. And you can see in Keynote 57, there are two cohorts because of that. And the two cohorts have different endpoints. The first cohort to read out was the cohort of patients with carcinoma in situ with or without papillary disease. And here the primary endpoints tend to be complete response. So the drug's given, a urologist looks back into the bladder. If they can't see any cancer on repeat cystoscopy, then there are serial cystoscopies. And you can see in this cohort, the complete response rate was about 40%. But you can see the Kaplan-Meier curve is the median duration of response in those patients achieving a complete response. So about 40% of patients achieve a complete response, and about half of those patients maintain their response at about 12 months. So the response rate with pembrolizumab is not too dissimilar to what we see in metastatic disease with PD-1, PD-L1 blockade and bladder cancer, which is that probably about 20 to 25% of patients benefit from the treatment. So certainly a strategy that can be offered. The only systemic treatment that we have right now to treat non-muscle invasive bladder cancer approved in carcinoma in situ based on cohort A. We only recently saw cohort B within the past year because this is a time-to-event endpoint. It takes longer for the trials to read out. And here I'll call your attention to the total population, so the green line. And you can see that at 1 year, 43.5% of patients were disease-free. Previously, the FDA, along with some investigators, had made a line in the sand that on a single-arm study, if that number was above 30%, that was looking pretty good compared to historical controls. And so this now has NCCN guideline recommendations for this group of patients as well. To shift gears to a device rather than an intravenous treatment, we spoke a little bit about TAR-200. And so TAR-200, this device that's inserted into the bladder, that leads to sustained release of gemcitabine. And the development program for TAR-200 has been really interesting. So the first study they do, the phase 1 study, is inserting this device in patients who are going to have cystectomy anyway. And this is a really nice design because they can, one, make sure that the treatment's tolerated, and two, assess the response to treatment in that surgical specimen. And so TAR-200 is inserted into the bladder, stays there for 21 days. When the urologist goes back in with a scope, they retrieve that old device, put a new one in. So this is given before cystectomy in this study, and there were some patients who achieved a pathological complete response. So really intriguing data, and that led to a huge development program for TAR-200. The most advanced data for TAR-200 is exactly in the same clinical disease state as what I just mentioned to you for pembrolizumab, and that's for patients with BCG-unresponsive non-muscle invasive bladder cancer. And there are 2 cohorts again. I'm going to show you the cohort of patients with carcinoma in situ. And here you can see the complete response right here is 80%. And you can see in the swimmer's lane plots, the dark blue indicates patients in a complete response. The light blue, those patients have not yet reached their assessment. So you can see all those patients at the top in a sustained complete response with this device with gemcitabine inserted into the bladder. Incredibly promising results compared to what we've seen historically in this patient population, and we'll see the full cohort results from this study sometime in the not too distant future. This is a well-tolerated device for the most part, mostly urinary symptoms, urinary frequency, some burning, can be UTIs. Shifting gears to muscle-invasive bladder cancer, we know that surgery alone can be curative for muscle-invasive bladder cancer, but unfortunately the risk for recurrence is quite high. And there have been a series of challenges that have prevented us from improving the outcomes of patients with muscle-invasive disease post-cystectomy. And those mainly have to do with us not knowing who needs treatment, not knowing who benefits from treatment, and not having drugs that were non-cross resistant with neoadjuvant chemotherapy in patients who got neoadjuvant chemo and then had residual disease. So we have 3 phase 3 trials of adjuvant immune checkpoint blockade. These are all designed pretty similarly, and they all really use the same inclusion criteria. That is, patients who had received neoadjuvant chemotherapy but have T2 or higher disease in their surgical specimen, or hadn't received neoadjuvant chemotherapy and had pathological T3 or higher disease in their surgical specimen and are cisplatin ineligible. And here you see the results from Checkmate 274 with nivolumab meeting its co-primary endpoint, showing an improvement in disease-free survival in the intent-to-treat population in the patients with PD-L1 high tumors. Overall survival in this study is a secondary endpoint. We haven't seen those results yet. It's an event-driven analysis, but we will see them at a meeting within the next year. Here are additional secondary endpoints, all pointing in the same direction. So non-urothelial tract disease-free survival, metastases-free survival, all favoring nivolumab versus placebo in that study. And the safety is what you would expect with PD-1 blockade. Quality of life was not deteriorated in patients who had received adjuvant nivo versus placebo. The Ambassador study just recently presented at ASCO GU, so this is with Pembro instead of Nivo, very similar trial design. And here you see again, in the intent to treat population, DFS is improved with Pembro compared to observation. In the PD-L1 high population, there is also a trend toward benefit, although the effect size wasn't quite what we saw in the biomarker-enriched population in Checkmate 274. We have seen overall survival data from Ambassador, but this is immature data. It's not the final analysis. So far, no definitive OS benefit from Pembro, but we will see a future final analysis. I'm just going to close up by talking briefly about ctDNA. So in the IMvigor10 study, so this is the same study now with atezo, that study didn't show a benefit in terms of DFS or overall survival for reasons that are not entirely clear because it was designed pretty similarly to the other studies. But retrospectively, the investigators went and looked back and said, would ctDNA have made a difference in this study? So they applied Signatera testing to this data set. And you see this is the observation arm separated by detectable versus undetectable ctDNA. on cycle 1, day 1, and you see a marked prognostic impact from ctDNA. And now when you look at patients stratified by ctDNA status receiving atezo versus observation, you see all the benefit of adjuvant atezo seems to be in patients with detectable ctDNA versus those without. So there are a number of now prospective phase 3 studies seeking to establish the clinical utility of Signatera testing to make adjuvant treatment decisions in bladder cancer. This is the IMvigor11 study. We're going to see some preliminary data from this study at a meeting in the upcoming future. And then this is the Alliance Modern study being done throughout the United States. If you're a member of the cooperative groups, you can open this study. And this study is randomizing patients after cystectomy based on ctDNA testing. If there's detectable ctDNA, randomized to Nivo versus Nivo plus relatlimab, the LAG-3 inhibitor. If undetectable ctDNA, randomized to nivolumab versus observation, with only initiation of nivolumab if there's a conversion of ctDNA from undetectable to detectable. So I'm going to stop there. Just one quick mention back to TAR-200. So to circle back, TAR-200 is also being developed in muscle-invasive bladder cancer, and this phase 3 study is comparing TAR-200 plus PD-1 blockade systemically for the treatment of muscle-invasive bladder cancer versus chemoradiation. So trying to develop a regimen without surgery and without radiation to treat muscle-invasive bladder cancer, a very innovative trial design. And I'll stop there.
John, can you kind of elaborate more on bladder sparing strategies that are being looked at right now?
So there are multiple approaches. Some are combining immunotherapy with chemoradiation. There are trials looking at biomarker selection and response to chemotherapy to identify people who may not need a surgical resection. One of those was reported as Retain, wasn't particularly successful with their biomarker strategy. There's one with the Alliance still ongoing that we haven't heard from any results yet. So there are a variety of interesting and novel approaches to try to see if patients don't have to give up their bladders, because as Harry Herr used to say to me when I first started MSK, the best bladder is the one you're born with, and that's really true.
So I want to go on in a second and talk about metastatic disease, but we've talked a lot about erdafitinib, and another agent that's really interesting, and I know, Vic, you had questions about it. I'm curious whether you've ever used it, is erdafitinib.
Yes, I have. In 2 patients, one didn't tolerate it well, just a lot of, I think, issues related probably to phosphate despite checking, correcting, all that stuff. The second gentleman was responding, tolerating well, but did develop central serous retinopathy. But interestingly, even after stopping the medication, he's been off the medicine now 4 months. Responses are durable. He's on no systemic treatment. He probably got treatment for maybe about 2.5 months or so, maybe 3 months. And so those are my 2 patients I've experienced with.
But the patient who had the central serous retinopathy, did they have any symptoms or visual issues?
Yes, he did. He had started to develop some blurry vision. He was going for regular eye checkups, and that's how it got picked up. So we stopped it fairly early, and he recovered from it.
So he totally recovered from it?
He recovered, but he didn't want to re-challenge it. We wanted him to re-challenge. He said, I'm not going to take a chance on that. Plus, I think we have new options, which he hasn't seen yet. So it's a discussion. Right now, he's just an observation.
You also mentioned problems with the phosphate in the other patient. And Matt, I've been curious since I've been hearing about this, exactly how this plays out. I hear from investigators, but not too many, the average doc hasn't used very much erdafitinib. What happened with the patient, and what kind of issues have come up with phosphate?
Yeah, he had CKD, creatinine baseline around 1.8. So he did develop, and we started with lower dose, as is recommended, and checked the phosphate levels. And his main complaint was weakness. He said, I'm just so weak, I can't function like that. And then he was also not the best performance score to start with. His phosphate levels climbed quite a bit. He had significant, and then we dose interrupted, tried to re-challenge him, but it did not go well with him. So he didn't want to continue on the therapy.
Matt, any thoughts about the case? Do you see more problems with people with chronic renal failure and with erdafitinib?
No, I can't say that I have. And, the phos we talk about a lot because it's unusual compared to other drugs that we give, but it's a very manageable side effect. You add phosphate binders in consult patients, and that tends to be pretty easily manageable. The skin and nail toxicity tends to be a little bit more of a challenge, and that can make people pretty miserable. And so this is a drug that there's a learning curve, and you have to get used to it. You have to be careful with reducing the dose and even being a little bit creative about the dosing strategy. But it can be an incredibly effective drug. The responses that you tend to see are reminiscent of oncogene-addicted tumors and other solid tumors
Really?
like lung cancer. You can see like melting away of
Really?
disease. So I think it gets a little bit of a bad rap, but this could be quite a good drug. You just have to know how to use it.
Any clinical pearls to add to that, John? Does diet help in terms of phosphate?
I think putting them on a low phosphate diet is helpful, although most patients have a hard time really sticking to it. And I think monitoring it and putting on phosphate binders and sometimes dose reduction are the way to go. But that tends not to be the barrier for me. I mean, it really is the skin, the nail, and oral toxicity that you get with it.
What about the ophthalmic issues? Is it just central serous retinopathy, or see other things with it?
I think you can see other things like keratopathies,
Dryness?
The corneas, but that's not a classical thing. It's, I would say, more unusual. But the central serous retinopathy is a real issue. I give everybody an Amsler grid or tell them to print it out at home and have them check their vision. And if
Really?
start
So they
seeing
check it
squiggly-
themselves?
Yeah, well, we send them to the eye doctor too, but if they notice anything in between that they're starting to see squiggly lines,
That's
we get them in
interesting.
sooner.
I have heard people, Vic, talk about the challenge in getting patients to regular ophthalmology.
Yeah, so I have right next to my office, I have a wonderful ophthalmologist, great, and we have about 4 drugs now that all need eye exams. He's been fantastic.
Great.
They keep a slot open, get them in quick, so I've been very lucky.
That's awesome.
Just want to clarify on the other gentleman who stopped. He also had brain mets, he had brain radiation, so his was a complicated situation, but I agree that the responses are very durable. The other gentleman, like I said, 3 to 4 months off therapy and still scans are good. So it's quite an impressive therapy.
Speaking of targeted therapy of the lung, does it work in the brain, erdafitinib?
I'm not sure. I haven't had that.
Luckily in urothelial cancer, we just have not seen a lot of brain metastatic disease. It's possible with some of the newer treatments.
You just had a case.
Yeah, I'm just pointing out that that's pretty unusual for urothelial cancer. Hopefully, we won't see what we've seen in some other solid tumors, where as our systemic treatments get better and better, we're seeing the brain as a sanctuary site.
But I wonder if it would respond in the brain. That would be
That's a great
interesting to
question.
see.
Small molecule.
All right, let's again get back to some data. We're going to talk about metastatic disease, John.
Great, thank you very much. Lots of changes. Used to be a talk you can give the same for about 20 years without much difference, and now changes every couple of months. Starting out with a case, this is a 58-year-old man with a history of intermediate favorable risk prostate cancer, got HIFU 4 years ago, who presented with hematuria in 2023. And at his first imaging, unfortunately showed thickening of the bladder wall and low-density liver lesions, measuring just under 2 centimeters. TURBT showed a high-grade, poorly differentiated muscle-invasive urothelial cancer, and a needle biopsy of the liver demonstrated metastatic urothelial cancer. He had right PCN placed to decompress that kidney. His renal function was starting to decline, and this was within, relatively recently after EV-Pembro was approved, and started on EV-Pembro, tolerated it generally quite well, and after 3 cycles, the liver lesions had completely disappeared, markedly decreased bladder wall thickening, noted increasing peripheral neuropathy, which was grade 1 essentially in its effects. Actually just had scans yesterday, which looked great, a continuing regression of the bladder tumor, continued CR in the liver, and so we'll be continuing on therapy.
Was that kind of what you were expecting when you started therapy?
I was expecting something like that, yeah. Based on everything we've seen, the responses are quick, CR rate is high, and so this is the sort of stuff we hope we're going to see. And this is what recapitulates in many ways what was seen in EV-302, which was the randomized trial that led to the full approval of EV-Pembro in the United States and will lead to approval around the world. So randomizing patients with metastatic urothelial cancer to either EV-Pembro or gem platinum, either cis or carbo, incorporating patients who are cis ineligible and eligible in the same trial. And with dual primary endpoints, it could have been positive with secondary endpoints listed. And when it's positive and really positive, you know it. You can drive a truck through these curves. The risk of progression or death was reduced by 55% with EV Pembro compared to chemotherapy. Really dramatic reduction with a doubling of PFS. And recent data reported at the GU Cancer Symposium, didn't matter if you were cisplatin eligible or ineligible, the hazard ratio was essentially the same. In fact, the cis ineligible patients, the hazard ratio was even better, 0.43 versus 0.48. And that's not statistically different, but slightly different. And PD-L1 score also didn't really matter. The combination is about as good in PD-L1 low patients as in PD-L1 high patients. Looking at sites of metastases, visceral Mets do much better with EV Pembro, lymph node only Mets do much better with EV Pembro, and liver metastases do much better with EV Pembro. Although I would say that the absolute values for liver Mets is, for the median OS is shorter in patients with liver metastases. And then overall survival, dramatic reduction in risk of death in overall survival. Rightly got a standing ovation at ESMO when this data was shown with a reduction of 53% on dying. And looking at subgroups, again, it sort of blows away all of our previously held assumptions of bladder cancer, whether you're cis-eligible or ineligible, PD-L1 high, PD-L1 low, regardless. The hazard ratio is essentially the same. And in fact, the cis-ineligible patients, again, seem to look even better with EV Pembro. You can see the time to event endpoint numbers on the slides. Liver metastases also did much better in terms of overall survival. Again, the absolute survival is lower. As you might expect, it's a poor prognostic feature, but they did much better with EV Pembro than chemotherapy. And so, who doesn't this work for? When there really isn't a subgroup that doesn't seem to benefit from EV Pembro, from what we can see. The response rate is 67%, and a whopping 29% of patients have complete responses. We really haven't seen that before compared to chemotherapy. And so this has supplanted platinum-based chemotherapy pretty quickly for almost everybody. Toxicity profile, as alluded to earlier, is different than chemotherapy, so you see more neuropathy and skin issues and much less cytopenias, and much less nausea than you might with platinum-based chemotherapy, but they both cause fatigue, which is not really all that different between the types of regimens. And so other GI symptoms, skin and peripheral neuropathy, tend to be the things you're worrying about. And this just goes to look at special reactions, reactions of interest in terms of sensory motor neuropathy. About 2/3 of patients will have any grade, and about 7% will have high-grade toxicity, which is much higher than with chemotherapy. I always tell patients that peripheral neuropathy is almost a sign of success of the regimen because you're on it long enough to get it. That if you are only on it for 4 months with cisplatin and you don't get it, that doesn't mean you wouldn't have gotten it at 9 months, whereas you might be on EV Pembro for much longer. Hyperglycemia is an issue. There are very rare patients who have very severe hyperglycemia. And skin toxicity management is the real challenge for many people. And the rashes are very different. There's the sort of intertriginous rash versus the blistering rash versus, and the management is a little different. There's actually an article put together by Mario Lacouture that I was an author on from a couple of years ago on EV management of skin toxicity, and I don't think it's really any different than with EV Pembro and topical steroids. They have a whole algorithm, and we have the algorithm in the manuscript that I think is pretty useful. Switching gears here, so one actually data set that I'm not talking about is nivolumab and chemotherapy, which was recently approved by the FDA for metastatic bladder cancer, but I'm not sure there's a role for it at this point, so I'd like to not talk about it. The Thor study is actually erdafitinib in the second or third line setting, randomizing patients to erdafitinib following failure of chemotherapy or checkpoint. Everybody had to have had a checkpoint inhibitor in the first or second line setting, and patients are randomized in this cohort of people who were post-checkpoint, erdafitinib or chemotherapy. And this was the cohort that led to the full approval of erdafitinib recently for metastatic urothelial cancer. And on the left, cohort 1 is the randomization to chemotherapy after a checkpoint. And you see an improvement in overall survival with a hazard ratio of 0.64 compared to taxane or vinflunine in post-IO patients, regardless of prior chemotherapy in the first or second line setting. However, in patients who haven't received a checkpoint, when you randomize erdafitinib to pembrolizumab, there is no improvement in overall survival. The outcomes look very similar, and you can see the curves kind of dance with erdafitinib doing better at the very beginning, but the checkpoint inhibitor doing better later. And so most patients, if they're going to get erdafitinib, should have seen a checkpoint inhibitor. Now with the shifting landscape, with everybody receiving pembrolizumab in the first line setting with EV, it shouldn't matter so much. And so erdafitinib, while the toxicity is real, is a survival prolonging patient in a FGFR3 mutant urothelial cancer with metastatic disease or fusion disease. The adverse events we talked about in some depth: hyperphosphatemia, GI toxicities, skin and nail toxicity, and CSR and other eye disorders. And when the eye disorders happen, they can be frustrating because you can have a patient who's responding very well and you don't want them to go blind. I'm also going to talk briefly about HER2 alterations and HER2 targeted therapy in bladder cancer to finish up. So HER2 actually is one of the most commonly altered genes in bladder cancer and across tumor types. HER2 alterations are among the most common alterations among all cancers in solid tumors at about 15%. Many of them are mutations, some are amplifications, and then some of them have multiple alterations, more than one. And so there can be coexistence of mutation and amplification. And there's some thought that it's a subclonal event in some patients, that it can be enriched in the metastatic setting. And we recently saw results of the Destiny Pan-Tumor-02 study with trastuzumab deruxtecan, which had very high response rate in HER2 positive urothelial cancer, with 39% of patients having an objective response. And in HER2 3+, 56% of patients had an objective response. We saw time to event endpoints reported pretty recently from this study, really not mattering very much between 2 and 3+ in terms of time to event, with a PFS and OS of 7 and 13 months, respectively, and probably will lead to a pan-tumor approval. I would expect bladder cancer to be included in this. And so following on the heels of that, though, is data from disitamab vedotin. Disitamab is a novel HER2 antibody, vedotin MMAE, the same cytotoxic as in enfortumab vedotin. Initially developed in China, this is a study from China as a single agent with a response rate of 50%, PFS of 5.8 months, and OS of 14 months, so looking very promising as a single agent in refractory disease, at least one prior therapy. And a small data set that's been reported, there'll be more coming, with a PD-1 monoclonal antibody showing a response rate of 73%, very similar to EV Pembro in HER2 positive patients. And so this is being further developed in the United States in combination therapy trials. And so where this will fit in the longer term remains to be seen, but really HER2 targeted therapy, I think, is here to stay in bladder cancer.
So I'm kind of curious, we've been talking already quite a bit about HER2, but also HER2 testing. And like here, looking at this slide, one of the things I see is once we get outside breast cancer, we don't always see the FISH. You know, when you put HER2 1 or 2+, we're used to looking for FISH from breast cancer, but we don't always see it. So first of all, what do we know about either one of these ADCs in terms of what we would call HER2 low, which is IHC 1 or 2+ and FISH negative?
Yeah, not a lot yet. I think the 1 or 2+, there's some data with disitamab vedotin showing that there is activity. And with trastuzumab deruxtecan, I think there's going to be more data to come on that.
And Matt, I'm kind of curious, just based on the data, have you actually used TDXD in a bladder? Have you been able to get it? Because I hear people doing it.
Yeah, so I have been able to get it. You know, the first study, actually, curiously, was with a combination with nivolumab even before the single agent data came out. So we've had data with trastuzumab deruxtecan urothelial cancer for about 4 years now, and certainly that has been used to justify using the drug off label, and I've been able to get it on occasion.
Have you used dasatinib vedotin, either one of you? Any tolerability there issues?
So tolerability with DV, pretty similar to with EV, with a few notable exceptions. We're not seeing a lot of skin toxicity. You see a little bit, but not a lot, and that's maybe in part because Nectin-4 is pretty highly expressed in the skin, so a different target. With DV, maybe we see a little bit more LFT abnormalities, but you see neuropathy with both, maybe a little bit less with DV, maybe a little bit more in the way of GI toxicity with DV.
Vic, are you testing your patients for HER2?
So actually I was not, but incidentally I had run a panel on a patient who was relapsed refractory, and the Garden test came out with a HER2 overexpression. And I treated, the gentleman still on treatment, he's on trastuzumab for over 3 years, great response. And he had failed multiple lines of therapy. Single agent.
Objective response.
Objective response. We obviously started with some chemo combination at that time, but then since he's responded, he's quite amazing. So that's the only patient I have, and that was incidental. But now I'm testing, of course, with the information I'm seeing.
John, any thoughts about it? There actually, if I think back, breast cancer, they saw single-agent response to trastuzumab.
Yeah, there were historical trials that tried to do that, and at the time, there wasn't, the incidence was low enough that they couldn't actually accrue the trials. And so we don't really have a lot of data, but there's anecdotes out there about that, of course.
So if you know the patient's HER2 positive, Matt, how right now is that going to affect your therapy? I assume for localized disease, it won't affect it, although I don't know whether or not if you're doing bladder sparing, you want to throw in a little anti-HER2 chemo radiation, but particularly metastatic disease, where are you going to think about bringing in either TDXD or maybe dasatinib vedotin in the future?
So it matters clinical trial-wise now, of course, because DV is actively being investigated, and so there is some planning in terms of getting those patients on study. But in the absence of a study, DV is not commercially available. Trastuzumab deruxtecan has a different payload than EV, and so there's certainly rationale for using them sequentially. So second or third line setting in metastatic disease, a patient with HER2 overexpressing urothelial cancer in my practice now.
And again, we've been asking this question, but it's always interesting to ask in different subspecialties. John, again, in terms of TDXD and prevention of side effects, but particularly screening for ILD, do you do chest CTs and people who are asymptomatic?
Not more frequently than what I would be doing for imaging for their cancer, but any sign of pulmonary symptoms, yes, which makes respiratory virus season a lot of fun.
So again, you see subtle differences as you talk to different groups, but I want to thank all three of you for coming here today, and we're going to move on. Thank you so much.